All right, welcome. We're going to do a deep dive into cardiac stress testing. Look, whether you're on the wards or in the clinic, you're going to face this question constantly. Does my patient's chest pain mean they have a blocked artery? My goal here is to give you a really clear, guideline-based way to answer that question with confidence.
So, here's the game plan. We're going to start from the ground up, the why behind it all, the physiology of ischemia. Then we'll get into our toolbox, learning not just what the tests are, but how to pick the right one. And we'll wrap up with how to actually read the results and some key pearls you can use tomorrow.
Okay, let's dive right in with the fundamental question we're trying to solve every single day.
This is, without a doubt, one of the most common challenges in medicine. Now, for patients with stable symptoms, what the guidelines now call chronic coronary syndromes, stress testing is really a cornerstone of how we figure things out. It lets us see the functional impact of a potential blockage.
So what is a stress test really trying to do? Well, its whole purpose is to safely provoke the heart, to push it a little, so we can see what happens. You see, at rest, even an artery that's pretty narrowed might let enough blood through. But the moment you start exercising, that same artery becomes a bottleneck. We're deliberately trying to expose that critical mismatch.
So to really get how these tests work, you've got to understand the physiology. We need to look under the hood. And it all boils down to a pretty simple balance.
Think of it like a seesaw. On one side, you have oxygen supply. That's mainly your coronary blood flow. On the other side, you have oxygen demand, which is driven by stuff like heart rate and how hard the heart is squeezing. Ischemia is just what happens when demand outstrips supply, and a stress test is how we deliberately tip those scales.
And this concept, coronary flow reserve, is absolutely key. Healthy arteries are amazing. They can dilate and boost blood flow by 3, 4, even 5 times what it is at rest. But a significant blockage? It's like a kink in a garden hose. It physically limits that ability. It blunts the reserve. The artery just can't open up to meet the demand. And that's the exact vulnerability we're trying to find.
Now this is fascinating. This shows you the sequence of events when a heart becomes ischemic. And what's so critical to notice is that angina, the actual chest pain, is the very last thing on the list. Our modern imaging tests like echo and nuclear scans are so powerful because they let us see problems way earlier in this cascade, at the perfusion or the wall motion stage.
Okay, so let's see how that physiology builds our toolbox. You know, every stress test, no matter how fancy it sounds, is really just a combination of 2 basic parts, a stressor and a detector.
Think of it like ordering off a menu. You pick one item from column A, the stress column, how you're going to push the heart, and you pick one from column B, the detection column, how you're going to look for the consequences. You mix and match these, and that gives you every single stress test we use.
So let's start with the classic, the one everybody knows, the good old-fashioned exercise ECG, the treadmill test.
The best thing about the treadmill test is the incredible prognostic data it gives us. Seriously, how long a person can exercise is one of the most powerful predictors of their long-term survival. The big downside, though, is that its accuracy for actually diagnosing a blockage is, well, it's just okay. And this is crucial, it's basically useless if the baseline ECG is abnormal, like with a left bundle branch block or a pacemaker.
Next up, stress echo. This is where we bring in the power of ultrasound to get a direct look at the heart muscle.
A stress echo is basically the ischemic cascade in action. We are literally watching for systolic dysfunction. We look for a new regional wall motion abnormality. That's a fancy way of saying a piece of the heart muscle stops squeezing like it should when it's under stress. The huge plus here is no radiation, but the catch is the quality of the pictures really depends on the skill of the sonographer and the patient's body type.
Okay, now for nuclear imaging. Here, we use tiny amounts of a radioactive tracer to create these beautiful, colorful maps of blood flow to the heart muscle itself.
So with a nuclear scan, we're literally mapping perfusion. We inject a tracer, take pictures at rest, then stress the patient and take more pictures. A healthy heart lights up on both scans. A reversible defect is an area that looks fine at rest but goes cold or dark under stress. That is the classic sign of ischemia. And that's totally different from a fixed defect, which is cold on both sets of pictures and tells you there's a scar from an old heart attack. So what do you do if your patient can't exercise? Maybe they have terrible arthritis or bad COPD or they're just really deconditioned. Well, that's where our pharmacologic agents are a lifesaver.
The key thing to get here is that we choose the drug based on our imaging. Vasodilators, like regadenoson, are perfect for nuclear scans because they create a big difference in blood flow that the camera can see. Dobutamine, on the other hand,
makes the heart work harder. It revs it up just like exercise, which is exactly what you need to see a new wall motion problem on an echo.
Okay, so we've got all these options. How in the world do you choose the right one? It's actually really logical, if you just ask a couple of key questions in the right order.
This is always question number one. When a patient exercises, we get so much critical information about their functional capacity and blood pressure response that we just completely lose with the drug. So if your patient can walk, exercise is always the way to go.
And this is question number 2. Like we said before, if you see a left bundle branch block, a pacemaker, or big ST changes at rest, a simple ECG treadmill test is off the table. It's just not going to be diagnostic. You absolutely have to add imaging in those cases.
And this algorithm from the guidelines is fantastic. It helps us think through not just which stress test to pick, but also when we should consider an anatomic test instead, like a coronary CT angiogram or CCTA. A CCTA gives you a direct picture of the pipes. The guidelines basically suggest that if your suspicion for a real blockage is high, a functional test, like stress imaging, is often better to see what effect that blockage is actually having. All right, you've picked the test, you've done the test. Now let's talk about interpretation and, just as important, some of the common traps you need to avoid.
When you're looking at a standard treadmill test report, it is not enough to just look at the ECG tracings. You have to put 4 things together: the ECG changes, what the patient told you about their symptoms, their blood pressure response, and of course, how long they were able to exercise.
This right here is the classic ECG sign you're hunting for. 1 millimeter or more of horizontal or downsloping ST depression. That is the hallmark of ischemia during stress. Upsloping ST changes, much less specific.
And please, don't just say positive for ST changes. Calculate the Duke treadmill score. It's brilliant. It takes the 3 most important variables, how long they exercised, how much their ST segments dropped, and if they had pain, and rolls them into one powerful number that predicts their future risk.
Now, when we add imaging, we're going beyond the ECG. We're now looking for direct visual proof of ischemia, like a wall that stops moving on an echo, or a cold spot on a nuclear scan. This distinction is everything when it comes to making decisions. A reversible defect tells you there's living but stunned heart muscle that's at risk. That's a potential target for a stent or bypass. A fixed defect, on the other hand, is dead tissue, a scar. And generally, you're not going to help a scar by opening up an artery.
And it's not just about if ischemia is there, but how much heart muscle is at risk. Big clinical trials have shown us that patients with a large amount of ischemia, that 10% number on a nuclear scan, is a key one. Those are the people who are most likely to actually live longer if we intervene. These numbers are what help us guide our management.
Okay, let's talk about some common mistakes. First, remember, stress testing is for stable patients only, not for someone with acute ongoing chest pain. Second, always check the med list. Things like beta blockers have to be held, or you can get a false negative test. And finally, a tricky one. Remember that really severe balanced disease in all 3 arteries can sometimes fool a nuclear scan and look normal.
Okay, let's boil all this down into a few simple take-home rules that you can stick in your back pocket for your next day in clinic. I just cannot say this enough. You get so much invaluable prognostic information from watching someone exercise. Their functional capacity is a huge predictor of their health. Always choose exercise if you can.
This is a classic board question for a reason, because it's a common clinical mistake. An ECG-only test with a left bundle, a pacer, or big resting ST changes is just a waste of time. You have to add imaging.
And this just follows logically from the first 2 pearls. If your patient can't exercise, you reach for a drug. And remember to match that drug to your camera. Vasodilators for perfusion imaging like nuclear or MRI, and dobutamine for functional imaging with a stress echo. So the bottom line is this. Choosing the right stress test isn't a guess, it's a system. If you just ask, can my patient exercise? And is their ECG readable? You can confidently find your way through the options. And while looking at anatomy with CTA is getting better and better, understanding the functional consequence of a blockage, the actual burden of ischemia, that will always be a critical piece of the puzzle. Thanks for tuning in.